You are going to learn a ton about one of the most common causes of disease and dying in the United States. At the end of this episode, thanks to our special guest, you're going to learn about all things diabetes, including which one you can completely protect yourself from developing if you change your lifestyle. In honor of Defeat Diabetes Month, we're joined by Dr. Lisa G. Newman. Dr. Lisa G. Newman is a board-certified endocrinologist and has been practicing in New York City for more than 30 years. Her background is she's a proud graduate of UPenn, University of Pennsylvania, NYU, New York University Medical School, and Internal Medicine Residency Program. Dr. Newman has published clinical research in diabetes and diet supplements, which I'm looking forward to bring you back to talk about really soon. Thank you so much for joining us, Dr. Newman.
I got my fellowship in endocrinology at Mount Sinai.
Yeah, well, I know that you're a proud graduate of the Mount Sinai Endocrinology program in New York City. So thank you so much for taking time out of your busy schedule to talk with us. I really appreciate it. It's so good to see you.
Thank you for having me.
So I have to tell you, when I was looking for a board-certified endocrinologist whose clinical acumen I could trust to join us to celebrate and acknowledge Defeat Diabetes Month, I immediately thought of you. You have this kind of, in my experience, from my perspective, you have kind of like this intuition about what patients with diabetes need. So thank you for joining us. So can you talk about what brought you to the field of diabetes medicine, endocrinology? Fancy name for diabetes medicine is endocrinology. What brought you to this field?
Well, the endocrinology part is because it was a little bit unusual and different. I had a patient with hyperparathyroidism, which was a gland in the neck that can sometimes have a benign tumor that puts out too much hormone that makes calcium levels go up. And it was just very interesting and very different and unusual. It wasn't the usual, the heart, the kidney. And the diabetes part was for my grandma. My grandfather had diabetes, and he actually went blind and died of diabetes in his 60s.
Oh, boy.
So I would say that was kind of an influence
Sure.
and why I like to take care of patients with diabetes.
What made you decide you were going to say, okay, I'm going to become a physician? How did you come to the field of saying, you know what, I want to become a physician? Even before you said, you know what, I really am interested in diabetes. Was there one of those stories about like an aha moment you had as a kid or something, or as a teenager? You said, I really want to become a
As a
physician.
teenager, I volunteered at an animal hospital.
Oh,
And I watched them do surgery, and it was just so interesting. And I said, but my patients can't talk to me. I need patients that can talk to me. So, and I loved ER medicine. It was so interesting. You saw everything in the Bellevue emergency room, but you didn't get to see what happened to them after they left. So one thing leads to another in your experiences, and that's where you end up where you're happiest.
so if you were actually Dr. Doolittle instead of Dr. Newman, you would have been a veterinarian if your patients could have talked to you, if you could have talked to the animals, huh? Cool. So I wanted to talk to you about something. I have a family member who's in her early 20s who was diagnosed with diabetes at the age of 2 years old, which means she has type 1 diabetes. The problem is that when she tells people she has type 1 diabetes, they assume she's talking about type 2 diabetes, which is a giant epidemic, a huge, humongous epidemic in the United States. Everybody knows someone who's been given the diagnosis, and they tell her that she needs to diet and exercise and lose weight, which of course really pisses her off, I think rightfully so. Can you talk about the difference, please, between type 1 and type 2 diabetes?
Yes. So, type 1 is about 5% of patients, all patients with diabetes, and type 2 is a lot more common. It's 91%. So that might be why people jump to that conclusion. But both of them are increasing in our country. Um, and type 1 diabetes is an illness where the body makes an antibody against the cells in the pancreas that make insulin. And it's an autoimmune disease where basically these cells get destroyed and they become insulin deficient, and they can actually die without insulin. They can go into something called diabetic ketoacidosis, where they get very sick. And so usually they don't die. They just get very sick and go to the hospital for a few days and get insulin and intravenous fluid, and they're fine. But they really need insulin to live. Type 2 diabetes is more, they're insulin resistant. The cells are resistant to insulin. And so their pancreas cannot, it works harder and harder and can't keep up after a while. So they become insulin deficient, and then their blood sugars go up too. And obesity, some people just have bad genetics for insulin resistance, and they can be thin and be type 2s. But for a lot of people, it's obesity increases insulin resistance as well and leads to type 2 diabetes. So they sometimes require insulin to be in good glucose control,
Type 2
but
people with type 2
for
diabetes
type 2,
sometimes often need
require it,
insulin.
but they
Okay.
aren't dependent on it to live. They can go into diabetic ketoacidosis if severely stressed,
Mhm.
but it's not common, and they don't commonly die without insulin. It's a totally different thing. Their pancreas isn't wiped out like it is with type 1 diabetes.
So back in the day, like really almost 100 years ago, I think it was in the 30s or the 40s that insulin was discovered, that the diagnosis of diabetes was a death sentence. People thought of it as like being diagnosed with a very aggressive cancer because it was type 1 diabetes. These were, diabetes we're talking about type 1 diabetes that would happen as a result of, they didn't know it at the time, but an autoimmune disorder, the antibodies killing the cells that the pancreas uses to make insulin. So you have zero insulin, type 1 diabetes. That was a death sentence. So I read about medical history and that kind of thing, and they talk about, 100 years ago in the 1920s, 30s, that was a death sentence period when a child was diagnosed with type 1, or when they would say diabetes, we know now is type 1, or they used to call juvenile diabetes.
Mhm.
So I just thought that was interesting and
So what happened
historical
at
perspective.
first was we had insulin, advancing and best, thanks to them, we have insulin. And then over time, our insulins developed to become even better insulins. So, first it was, pork insulin and cow insulin, and now it's, synthetic insulin. And there's different kinds of long acting insulin to provide the background insulin that the normal pancreas makes. Um, and then there's the rapid acting to go with just a bolus before meals. And there's several different kinds of each now. So, so first was development of the different insulins, and then was amazing technology. So I think being able to test your blood sugar at home by pricking your finger and putting it on a strip in a machine, I think that was really in the late 70s, 80s.
Oh gosh,
And that
even more recently than I thought.
was
Okay,
really, really helpful for patients
sure.
to know what was going on in their body. And then we had a blood test, a hemoglobin A1C, which showed the average blood sugar control over the prior 3 months. And then 1990 was a landmark study that showed in type 1 diabetes that showed that if you were able to get a good level for that A1C, less than 6.5, then you had less complications of diabetes, meaning the blindness, the amputations, kidney disease, and even the cardiovascular disease. And later studies showed in these patients, the earlier you were able to get control, the better they did. There was kind of some memory. And so there's a real correlation with this 3-month blood test. But now we have something even better, or
What's
something
that?
something to
Oh my
add to
gosh.
that.
Uh,
So
Tell us
hemoglobin A1C is a blood test that shows the mean blood sugar. So
the average
you can
mean
have an
means
average.
average blood sugar over the prior 3 months.
You can have an average where it's very close to perfection all the time, or you can have an average where it's very low sometimes and very high sometimes, and it still goes to average to the same level.
Good point.
So they studied variability of blood sugar and said, is it important? And they found, yes, it's important for complications of diabetes. The less variability you have, the better. Plus, if you're too high, you can go into diabetic ketoacidosis and get very sick. And if you're too low, you can get hypoglycemia and, be dizzy, fall down and hit your head. So neither extreme was good anyway. And so they had developed continuous glucose monitors.
Oh,
Yeah.
right. Okay.
So
Yeah.
so you don't have to prick your finger. So it's both a boon because it's not invasive. You don't have to prick and hurt yourself 7 times a day, before meals, 2 hours after meals to see how your bolus did for your food, and then at bedtime to make sure it was safe to go to sleep, or you were in a good level. Now you just wear this little sensor. It's a little patch. You wear it on your belly or you wear it on your arm, and every 5 minutes, it's measuring the blood sugar in your body and sending it. Used to be to a receiver. Now it's to your iPhone or your Android. So that is amazing. That
That's a
is
big
amazing.
deal. That was a game
And
changer.
it's a game changer for 2 reasons. One, and I'm going to show you the screen in a minute, but you can go and you could see, like, say 2 weeks, and you could see how much you are in range and how much you are low and high. But the other thing that I love about it, before I show you that screen, is it's not only control like that, but you can also set alarms. So you don't have to worry. I used to have the nurses wake up patients at 3 a.m. when I changed
Oh
the insulin regimen to make
gosh.
sure they didn't get hypoglycemic.
Yeah.
So now you have alarms to set on these continuous glucose monitors for high and low. So if it's over 250, it can alarm. If it's under 70, it can alarm. Not only for absolute values, though. If it's trending, going down too fast, if it's going up too fast, it can also alarm. So you can really, stop things from going bad real fast. Um, so
It was a huge game changer for my family member who has type 1 diabetes. She sets her alarm and it
go to
actually
sleep and she's not going to die, and she's not going to get in trouble in
in
her
the
sleep.
middle of the night, yeah, and she has backup. So, like I said, she was diagnosed when she was only 2 years old. So it was a big, huge game changer in the last, I would say, 7 years where, yes, the alarm, she can set an alarm for when she's high, if she goes above 250, let's say, or she can also set an alarm for when she doesn't want to go below, let's say, 80. And also, and this is big deal for type 1 diabetic because they're usually young, they're usually kids, children. Those alarms also got sent to her parents.
Right. You
That
can
is
share
huge.
up to you can send up to 10 people. You can share. So you could share with your doctor. You could share with, both your parents,
Yes.
share with the babysitter. So, anyone who can help you can see the data at any time.
And,
So,
and wake up in the middle of the night and say, "Hey, you're running low. Let's get some juice. Let's get some apple juice."
well, there's a
Or you're
new
running
development.
high, let's
There's a new
what do we do?
development that
Tell us about that. Tell us
I'm
about
gonna
the
tell you
development.
that they don't even have to do that, but first I just wanna show you the screen
Oh,
because
yes, show us.
and you're not gonna believe that this is actually a patient I saw the other day. And can you see that bar graph?
I can't. The light is blinding it. The
Okay.
screen is the light is
Oh,
blinding it.
I wish I
It's
could change
reflecting
it.
back.
Um, all right. Well, there's a bar graph. So what I'm trying to say is there's a screen that patients come into the office and they show me 2 weeks of data on this continuous glucose monitor. And
2
in
weeks of their glucose levels.
yes,
Yes.
but put into bar graph form for the level of glucose, which I'll go over in a minute, and also 24-hour glucose curves, composites from midnight until noon. So you can see where the glucoses were and where the trouble is over a 24-hour period. And so this takes like 2 minutes to see less to see what's going on in their bodies, like in so many different ways. So we have goals for this variability. We want the time in range 70 to 180 milligrams per deciliter to be more than 70%. We want those very lows before 54, below 54, where they could really pass out and hurt
Right.
themselves and even die if it really got to,
Correct.
low. We want that to be less than 1%. A little bit low between 70 and 54 where they feel a little woozy and they can correct it themselves with glucose tablets or, some juice. That is less than 4%. And then the highs, a little more leeway, from 180 to 250 can occur in 25% or less. And the very high over 250, we want to be less than 5%. So this is bar graph of where the patient is. And my patient that I saw the other day is 94% time in range,
Yeah.
less than 1% low and very low.
Nice.
And like, 4% high and like less than 1% very high. And in 2 seconds, I could see that because it's a bar graph. And then I see there's the curve, the 24-hour curve has red lines for the time in range. So it's 70 and 180. And her glucose is all within that little range. And there's also a coefficient of variation you calculate from the standard deviation they give you on that screen and the average glucose. And it's supposed to be less than 36%. Hers was 24%. And they also give you this number called a GMI, glucose management indicator, that's kind of similar to an A1C, and hers was 6.2%. So you get
Beautiful.
all this information on one screen, and in 2 minutes, you see everything. And she had no problems. But somebody else is like 68% time in range, and they have too many lows. You just look at that 24-hour curve, and you can see where the problem is, and just adjust, what's going on.
So as you know, not too long ago, this was impossible to get because it was a guessing game. People would wake up high and we couldn't figure out, well, were they high because there's a physiologic thing that happens overnight, that kind of thing that you're actually low. And so that you're actually kind of like a rebound effect. Your sugars go high, that kind of thing. And it was a real guessing game. And well, let's try this, let's try
Well,
that.
we had to do at 3 a.m. to think to
Yes.
see if
This
it was
was
the dawn
so
phenomenon
difficult. Yes.
or whether it was rebound hyperglycemia,
Yeah.
the issue was. And now we don't have to. Plus, because they're in control so much better, they see me once or twice a year. I used to have to see them every 3 months, and I still would go over exercise, we'd go over, alcohol use, we go over everything, and it would be so hard to tease out, the different issues, or maybe we'd concentrate on one meal at a time and just work on dinner. And now they come in. I'm lucky if I see them twice a year because they're in such good control. So it's easier for them. It's easier for me. Um, then, of course, there's insulin pumps, which have dramatically increased in use over the past 10 years. And they're amazing. And what's really amazing now is the automated insulin pump.
Okay, tell us the difference between the insulin pump and the automated insulin pump, because that was the huge game changer for type 1 diabetics in terms of not having to prick themselves all the time and the fragility, going up, down, la, 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 la. This is huge.
So,
I know
so the,
about the insulin pumps, but
so
I don't
the,
tell me about the automated. Talk about the automated insulin pumps.
So you had the continuous glucose monitors, the Freestyle and the Dexcom. And then you had insulin pumps, is basically in this country, Medtronic, Omnipod, and the Tandem T-Slim. And so those were great because you didn't have to draw up and inject insulin 5 times a day. So that was a major improvement. So now we have the third step, automated, that puts together the continuous glucose monitor with the insulin pump with a third component, which is basically an algorithm of how insulin delivery should be changed in accordance to the blood sugar and the trends seen by the continuous glucose monitor. So every company has a different setup. So Medtronic uses a Guardian CGM, and they have SmartGuard as their kind of algorithm. And Omnipod 5 uses either Freestyle now, they do Freestyle, or the Dexcom G6 system. And they have, I think it's called Smart Control. And Tandem T Slim uses Control IQ and the Dexcom. And I think they're working on getting the Freestyle. But could you imagine? First, you don't have to give injections. Then you don't have to prick your finger. And now you don't even have to do anything. In the beginning, there's some artificial intelligence. The machine has to get used to your body and how how sensitive you are to insulin and exercise and different things. But it has really freed up the patient.
How
And
long have the automated insulin pumps been out, Dr. Newman?
well, the Medtronic was the first one, but it really took. It's really not until recently. I'd say the past couple of years that it's really been effective and useful, because it took time to work out the kinks.
Sure.
So the interesting thing is there was a paper published that a lot of the young people are very computer savvy. And maybe they don't have the best insurance. Maybe their insurance wasn't covering things. They made their own automated pumps. People publish their algorithms
Oh my
online.
gosh, you know what?
And
I
then
remember
kids
seeing that
downloaded
last
it.
year.
The kids
I forgot
downloaded
about
the
that.
algorithms
Yes.
and together they had an automated pump. And they did a study, and I think it was published. It might have been in the New England Journal of Medicine. Very, very good
I
study.
remember
And
seeing
it
that.
worked.
Yes, it worked.
I mean, I really would rather they have, one of the systems that we,
That would be ideal, but
but if they can't, I could
Yeah.
not believe that. And I think it's because they're really a techie generation, and
Sure.
they can really do it. And that was amazing. And so that's just wonderful. I mean, they still have to have all this equipment. They still have to change the sensors either every 10 days, every 14 days.
Apologies, Dr. Newman, they still have to change their what?
The sensors?
Their sensors,
So
yes.
then you're the little circle
Every week. Yes.
that picks up the blood sugar.
Yes.
So they have to change it every 10 days for
Yeah.
the Dexcom, every 14 days for the Freestyle. They still have to wear these things. They're water resistant, but not, they can only be under the water like 3 feet deep for 30 minutes. So there still are limitations. There still is expense. I had one patient who is, this is the first patient that I've had that had a problem with the technology. She is not in a relationship, but she's dates, and she's uncomfortable, showing the equipment.
It's a pump on the back of your arm or in your
Yeah.
abdomen. Yeah.
Yeah. She's uncomfortable with that.
Many people feel that it's not sexy to have this pod on the back of your arm or upper arm or in your abdomen. Yeah.
And also she felt like, oh, it takes my readings every 5 minutes. So every 5 minutes I can know what's going on in my body. And she felt like she was checking a lot. But lucky for her, she has an unusual, I'm not even 100% sure she has type 1 because I didn't see antibodies, and she has a normal level of insulin in her body. But she did present in Washington, D.C. with diabetic ketoacidosis 5 years ago. So she was always treated like a type 1.
How old was she at the time?
17.
Yeah.
And she does have some of her own insulin secretion we measure C-peptide in the blood.
All right. So C-peptide measures what?
So that
It measures actual insulin that the body makes.
That's right.
As opposed to insulin that you get from outside the body that you inject yourself with.
Correct. And the reason why it's so helpful if some of these type 1 patients still have some of their own residual pancreatic function is because they don't get as much hyper and hypoglycemia. They're much easier to control because you just have to give them a little insulin and then the body makes up the rest. So it's not like you're overdosing with insulin to get too much lows. And it's not like you're can ever underdose to get too much highs. And so she just wants to do finger sticks a few times a day and inject her insulin. And she just eats like 3 meals a day. So she's fine with that. And I think it's going to work for her for as long as her pancreas still puts out a little bit of insulin. So, but that's rare. Most patients can totally ignore it. Just let the machine do its thing and, just do their maintenance, whatever they have to do, and look at their numbers, every few days, and they're fine with that.
Good stuff.
But could you imagine being the parent of a 2-year-old? And not all of them are approved. They're certainly approved for age 4 and above, but some of them are approved for down to age 2.
You're talking
But
about the automated insulin pumps.
yeah, imagine
Yes.
being a parent.
Oh, yeah. It's a
and
life changer.
They go to daycare and you can see what's going on. And you can even use your iPhone to adjust things. So it's just wonderful. The other thing is that the treatment for hypoglycemia
Low
had low
sugars,
glycemic
low
has
sugar hypoglycemia.
has become so much easier. So you used to have the school nurse or your travel companion or a family member use this glucagon emergency kit that was very cumbersome. You had to draw up the fluid and put it in the vial with the powder for the glucagon, which is the counters insulin, so it raises blood sugar, and say, if you find me unconscious or not responsive,
Do
you
this and
mix
stab me with
this,
it.
give me an injection, call 911. So
Yes.
now they're actually getting rid of it because they have 2 better things. One is this called Baqsimi, which all they do is put this powder in the nose,
Wow.
a powder in the nose, and it gets absorbed by the blood that flows through the nose and nasal
How do
mucosa.
you spell that? I have not heard of that, Dr. Newman. How do you spell it?
Baqsimi, Baqsimi.
That is outstanding.
That's outstanding. Imagine being the school nurse. Have that
Right.
around. And the other thing is called a Gvoke hyperpen, which is already premixed. And you don't have to attach a needle. You just remove the cap, push the button, the needle comes out, then it retracts, and that's it. Nobody gets stuck with the needle, no fussing, no thinking. You're anxious when you see somebody that's sick. You don't want to have to think and do. You just want to
Exactly.
push. So these
Exactly.
are two, again, the last 5 years. These are two wonderful, wonderful things that have happened for the treatment of type 1 diabetes. So there really has been a lot.
Have you
And
been finding any difficulties with commercial insurances and even government insurances covering the insulin pumps, the continuous glucose monitors, and even the Baqsimi and hyperpen for type 1 and type 2 and or type 2 diabetics? There's a lot
so,
of pushback, I know, for type 2. Can you update us on what's going on with getting
so far,
coverage for that insurance?
type 2s can get these things if they are insulin requiring. So if you take insulin, you can get it. And I think that even goes for gestational diabetes, where they have to go on insulin during their pregnancies to protect the health of the mother and the baby. I think they can get it too. And I remember like CGM had just come out years ago.
Continuous glucose monitor,
Yeah,
CGM.
when I had a patient with type 1 diabetes who was just out of control during her pregnancy. And I said to her, let's try and get it, try and get it, and but it just really wasn't available. And it's just so much easier. They used to be some of my most difficult patients to take care of. And now
Gestational
they're
diabetes,
yeah,
diabetes
no, type 1
pregnancy. Oh,
diabetes.
oh,
Type
sure.
1 diabetes, and I
Yeah.
had so much to talk about, so much to look at, pages and pages of data, and now they're my easiest patients. I take 2 minutes to look at that screen on their Freestyle or Dexcom, data on their iPhone or their Android, and they're in better control. So I don't have much to say and do. I screen for the complications. I get the urine albumin, Brandy. I have them pee into a cup. I get the A1C. And with type 1s, I also screen for other autoimmune diseases once a year. There's the celiac, the B12 deficiency, and thyroid hypothyroidism. Make sure they see their eye doctor once a year, and examine them, examine their feet and their thyroid, and listen to their heart. There's really not much to do. There used to be like I couldn't get it done in 40 minutes. So
Yeah,
it's totally, totally different. I used to need the diabetes nurse educator. Now I can pretty much, because the company supplies the nurses to help them with the
oh, that's a good
machines.
point, yeah.
Or they can call the company if they're having a problem.
So is insurance covering also this, these newer kind of basically glucagon hypoglycemic treatment replacement? So
Yes.
you haven't had to have any conversations with insurance companies in your
No.
experience getting this covered?
No, I think they
Okay,
still go through prior authorization, but that's just a formality. And
okay,
every year the prior authorization is renewed. They bother you for that, but that it's just a formality. It's not a problem. What
okay.
I would like to see in the future, I really would like the continuous glucose monitors for my type 2s who are on sulfonylurea medications like glipizide, because they can cause hypoglycemia.
Their
And they're
sugars can
older
go really
people.
low and stay low for a while. That's a big
Yeah.
deal, yeah.
Yeah, so
So I'm correct then. So insurance companies are still not covering CGMs, continuous glucose monitors for type 2 diabetes. They have these parameters that you have to meet
you have
in
to be
your
on insulin.
experience. So
You have
just
to be on
insulin.
insulin.
So
Yeah.
if you can document that, then so they don't bother you about saying, well, you have to document that you've had highs and lows and
Yeah.
variability.
No,
They
just
don't
insulin.
have those rigid requirements. I've seen insurance companies that have rigid requirements for their type 2 diabetics to get CGMs.
I think it's changed.
Excellent.
It's
That's
changed.
wonderful.
Um,
It's awesome.
I just hope that, not that we're using glipizide too much, as much anymore, but there still is a place for it, for sulfonylureas like glipizide, and they can cause hypoglycemia. But also, if there is a type 2 that wants to, learn their body better and see how foods affect them, how exercise, wouldn't it be nice for them to be able to have it too, and they could be in better control too. So eventually, um, that perhaps they could be covered as well. I think if the machine, is $900 usually, around $900, and then there's a fee every month for, I don't know, $40 for the sensors. So it's not prohibitive, but it's still expensive for probably many people. They
It's a
have to
real
pay.
investment. It's, it is prohibitive for some people, for many people.
Yeah,
And if they wanted to
especially if they're
get
paying for insulin too.
exactly, exactly. I mean, there's good news that some of the big insulin producers, manufacturers are saying, okay, we're going to cap it, but it's still a lot of resources. And
Yeah,
so I'm finding that there are people who, if they're fortunate to have resources, they just go ahead and buy the CGMs, the continuous glucose monitors in cash.
right.
They just buy it themselves. They just
And
go and say, I
my
want it.
friend, whose father is in Italy, elderly, um, 80, and he was hospitalized, and he has a little renal failure, and they had him on insulin in the hospital because he had blood infection. Um, and they sent him home on insulin where he had gone in on pills. So he kept getting low because they had him on these big doses of insulin. His life was different when he was home. So he was an insulin requiring type 2. And then his kidneys weren't perfect, so he wasn't having some of the kidney. Our body can produce sugar itself from the liver and from the kidney, and he didn't have that, so he was at risk for low blood sugars. So I said, "Just buy him just have your brother in Italy buy him the Dexcom," and his poor wife, she had to, like, take care of him, set alarms, cut the insulin in half, have you can see what's going on in his body, you could see what he needs, but the poor guy was like he kept going low for, like, the first 2 days he was home, and then they
Oh
couldn't get the
gosh, and it's
doctor, and
particularly dangerous in the elderly. Hypoglycemia going too low is
yeah,
extremely dangerous for the
right.
elderly. So Good stuff. So
Yeah.
I really want to ask you, Dr. Newman, to just tell us, please, can type 1 diabetes be treated with diet and exercise and healthy nutrition and weight maintenance?
Well, that's not going to reverse the destruction of the cells by the autoantibodies.
Exactly. So
And
the answer is
so
no.
the answer is no, but treating obesity is
Right.
always important because unlike what the media will tell you when they talk about fat shaming, it is not a cosmetic issue. It is a medical issue. Obesity can be associated with not just with type 2 diabetes, but with high blood pressure. There's increased risk of cancers, heart disease, arthritis. It is it is a real disease.
So
And people
people
have
lose enough weight and work on their nutrition to stay at a healthy weight. Can type 2 diabetes be cured?
yes. Well,
Thank you.
it can be put in remission.
It can be put in remission.
We don't use the word cure yet. We say remission. Uh,
I think people like to use the word cure, but you can totally put it in full remission if
right,
you do the things that include working on your nutrition so that you're able to stay at a healthy get to and maintain a healthy weight. Then you can get rid of you will no longer need treatment for type 2 diabetes, and you will no longer need to be treated for type 2 diabetes. So I just
right.
wanted you to
So
make
the reason why
sure
we
that
know that
you talk about that and clarify that so that my poor family member who gets these essentially these judgmental, they don't know what they're talking about when she says, "Well, I need this because, I'm a type 1 diabetic." They're like, "Yeah, you really need to like lose weight. You should exercise and eat better." I really I just wanted you to say that just for this family
right.
member so folks know that. So we're educating folks on
Oh,
what
yeah.
the real cause of
You know what?
you
They
can
can make them feel
reverse type
bad.
2 diabetes. I'm sorry, say that again, Dr. Newman.
Should make them feel bad and say, "I understand where ignorance is coming from, but there's a 5% of patients with diabetes who actually die without insulin."
Yes,
And
yes.
it's terrible when people are ignorant and just wanna make people, I don't know,
Feel bad.
feel bad.
Being
But
judgmental
we know
is not
about
helpful or productive.
yeah, but, there there's so much to talk about with obesity, and I had prepared for a talk, part of the talk on type 2 diabetes and obesity. Um, but I did wanna do one more thing about type 1 diabetes because
Please.
if you ask me what people wanna know and what excited me,
Yeah. Dr. Newman, tell us, what does your
prevention of type 1
diabetes doctor want you to know?
that they are working on preventing type 1 diabetes. And that is exciting.
That
That
is
is exciting because,
really exciting.
again, you don't wanna be a parent who has a two-year-old just diagnosed with type 1 diabetes, and it's still, it's still a lot, and it's a lot for a growing child. It's a lot. Um, so first they looked at there's actually stages of type 1 diabetes. So there's 5 different antibodies that they've identified that attack the pancreas to cause this autoimmune destruction. And they can measure them in the blood. And when you have 2 or more, that's stage 1. When you have 2 or more of these antibodies, but you also have a little bit of glucose intolerance, that's stage 2. And stage 3 is overt diabetes,
Interesting.
high blood sugars, right? Interesting, right?
Yeah.
So in November 2022, so 5 months ago, they approved a drug to prevent stage 2 going to stage 3.
No way.
Yes, and
How
it's
does that work? Can you explain
okay,
this? Can you talk about
yeah.
how that works?
So it's called teplizumab, and it's a protein, a monoclonal antibody that attaches to the cells that are destroying the pancreas, the immune cells, the T cells that destroy the pancreatic beta cells, and it prevents the destruction. So it's approved for patients above age 8 years, so not like they're really young. Um, But I'm excited because it's a good first step. It's not the total answer yet, of course, when things, we're in their first stages, but isn't it great that we've thought about this? We've gotten this far to put diabetes into stages, to measuring antibodies, to understanding that we can prevent it. The reason why it's not for everybody is because it's $193,000.
Oh my gosh, for
And
one.
it's
Oh,
an infusion that's done daily for
okay.
15 days,
Okay.
and it doesn't prevent it forever. The median time is 2 years. So you slow it, you prevent the prevention for 2 years. But there are some patients that take it, and 11 years later, they still don't have real type 1 diabetes yet. They still are
Wow.
stage 2. So, the people that if you could, get the price down to $50,000, then it would be worthwhile for a much bigger group. And then they found that there are certain, immune types. We all have what we call HLA typing,
Mhm.
um, and in our immune system, and DR3 and 4 are associated with, um, a bigger risk of type 1 diabetes. Not that they all get it, but a bigger risk. And out of the 5 antibodies, there's something called a zinc aid transporter, and that's associated with a bigger risk of progression. And so it might not be cost effective to ever give those patients that particular drug to prevent, because they're just going to go on to type 1
They're gonna
diabetes.
progress anyway.
Yeah, they're
Yeah.
going to
Yeah.
progress.
That
Um,
is really interesting.
but it's interesting that but is it worth it to give an 8-year-old who doesn't have that? Yeah, because the ages 8 to 10, they could be going through puberty. They're young.
It's a big deal.
That would be really helpful.
It's a big deal. The longer
Eh,
you can delay hyperglycemia, you actually add years onto your life on the other end. It is a huge deal. You're talking about adding years to
But
your
then again, if you have a 16-year-old, they're pretty much an adult. They've gone through puberty.
Mhm.
Why
You're
suggest that?
physiologically basically an adult. Yeah.
Why spend that kind of money for 2 weeks of infusions, and they're gonna have to just go on the automated pump anyway, and
Mhm.
they can do it easily. But an 8-year-old, no, it's a little bit more difficult. So, I was very excited about that, and I know that it's gonna get better and better and better, and there are actually 2 other things that are in the pipeline, and one was a small study on an old cardiac drug, an old heart disease drug, verapamil, an inexpensive pill. And they did a study in stage 2, and they found that they can they can keep the C peptide level, the
The
insulin that the
body's
body
insulin level
makes.
that it makes on its
They
own.
they could keep it higher with verapamil if they give it within the
The
first.
old-fashioned Verapamil that's like 50 years old or 40
Yes,
years old, really,
yes,
the blood pressure
yes.
medicine Verapamil, that is awesome.
Right, and they can, and as I said before, the more insulin that your own pancreas can make, the easier it is to control and to not get the low blood sugars. So, if they can do it, they did it within a month of diagnosis, and they kept the C peptide. So it's not really preventing it; it's more like keeping them with enough of their own insulin to make it easier to control. And so they have to find out, well, do larger studies, and can you give it 5 months after diagnosis, and it will do the same help. And then this ATG, anti-thymocyte globulin, that they use for transplant patients, they're also studying that to help prevent progression from stage 2 to stage 3. So the
An
point
antibody
is,
treatment,
what's new in type 1? They're looking at preventing type 1.
that
And they're
is
looking at staging it
huge.
and preventing it. And then they're looking at, well, who do we check the antibodies for? With
Ah,
16,
when do you start screening
if
antibodies?
you
At what
start
age and in
screening,
whom? Do you
right.
do it in every kid? Oh, there's a lot of work that's gonna be done, a lot of
Right. So we
exciting
know
stuff
that
that's coming out that we have to
60
look out for.
60 to 80% of identical twins will get type 1 diabetes. 4% if an adult parent has it. If a sibling has it, it's up to 10%. So, of course, you could think about screening those people. But 85% of patients with type 1 diabetes have no family
There's
history.
no family history. It is not
So,
connected.
they're-
There's no genetic link at
so they're
all.
thinking
Yeah.
Do we check the kids come in for their vaccines at age 2? We can check then. Then they come back maybe,
Exactly.
and you have to check twice because to pick up more. So maybe
Right.
it's age 4 or age 6
So
at a
age 2, 4, and 6
yeah, a
kind of
well
thing.
children visit or vaccine visit,
Oh
just
my
throwing that in.
exactly.
But then they're going back to looking at, well, maybe we should just add it to the heel prick that we do on newborns that check for so many things like congenital hypothyroidism and um,
Yeah, but they're not as you're not gonna
MS.
see it that early, though.
No,
Like
they'll see the HLA typing.
oh, the HLA typing. I'm thinking
They'll
about the
see they
antibodies
can
still,
look at
Dr.
the
Newman. Gotcha.
genes. They can
The
look at the genes of the
got
baby
you.
to
Got you.
see
Yeah.
if they have the predisposition
Yeah.
and at least test them for antibodies
Gotcha.
and follow them for antibodies.
So
So
screen them if they have the HLA, which is the immune type, the type of
that,
basically marker that you have the gene
yeah,
essentially, then they'll say, okay, you need to get screened for the antibodies at age 2, 4, and 6. That kind of
right,
thing. Gotcha.
right, right.
So that's outstanding information.
So,
Thank you for
so this,
sharing that.
yeah. So
What?
that's very exciting to think that they can
Yeah.
detect it early, so they don't have to. A third and half of them present in diabetic ketoacidosis. They're so sick, so you can prevent that. You can maybe treat them with some of these drugs or some other new drug coming out. It's just a really is a game changer and very exciting.
Awesome stuff. So, Dr. Newman, what does your diabetes doctor want you to know about the connection between overweight and obesity and type 2 diabetes? You said there was something you wanted to talk about with obesity from a diabetes doctor's perspective.
So we know that from the bariatric surgery studies, which is the gastric bypass, the lap band, and the sleeve gastrectomy, that a lot of patients get remission of diabetes. Uh, and
Type 2
and
diabetes
and they
really
get,
early on before they lose a significant amount of weight.
yes, that's
It's
a great point because
outstanding.
it affects all these hormones in the gastrointestinal system that are involved in weight regulation, like ghrelin in the stomach or the GLP agonists, one agonist in the intestine. And it's really amazing. And so, unfortunately, only 1% of people who qualify for the surgery wants the surgery. I guess it's a little much for people. But fortunately, we now have really effective drugs. And we know that if we can get 5% weight loss, we really help the patient metabolically. For
So
liver,
5% of your body weight, if you're overweight or if you have overweight or obesity, just 5% of your body weight makes a big difference in your risk for developing type 2 diabetes.
and other metabolic complications like high
Mhm.
blood pressure, heart disease, not fatty liver. Fatty liver, you need to lose 10%.
Okay.
But the new drugs, Wegovy, which is really one of the intestinal hormones, the GLP-1 agonist. Um, we had it as it's called semaglutide, and we've had it for many years, over 20 years, as Ozempic to use for type 2 diabetes, just for glucose control. And we found that that these patients lost a lot of weight. So then it got approved and approved in higher doses, even as Wegovy. And Wegovy, half the patients can get like 15% weight loss. So not everybody loses weight, but like 80% can lose 5% or more. So
And so
that's
this
it.
is the thing, the cost is prohibitive if your insurance doesn't cover it. And most insurances don't cover it for the indication of weight loss unless you have obesity, which is over a certain BMI, what BMI of 30, is that right?
So insurance has been paying for Wegovy if the BMI is over 30.
Okay, good to know. That's what we need to.
And it's wonderful to have that option. I just, tell patients that they need to eat smaller meals and they need to get the fat out of the meals. Otherwise, they're going to have the gastrointestinal side effects. And it doesn't get all the excess weight off, but again, it can get a metabolically important weight off. And then there's Manjaro, which was just approved, I think it was last June, for type 2 diabetes, not for weight loss yet. And that attaches another hormone to the GLP-1 agonist. It's a GIP. So it's another intestinal hormone that it works on the brain for satiety. It works on the pancreas to help glucose induced insulin secretion to help glucose control, and might even help with energy expenditure. And
So
they've
they're saying how much weight loss are they saying that they're noticing in
22,
their patients?
22%
Oh my gosh.
in a lot
Average
of patients.
22% body weight.
And again, not for everybody. And
On average, some
the
more,
more
some less.
overweight you are, the more weight you
Sure,
lose.
sure.
But
That's outstanding.
that's outstanding. So hopefully, eventually, that will be approved for weight loss.
All right, good
Um,
stuff. Thank you so much, Dr.
you're
Newman, for
welcome.
sharing all of your really hard-earned insights of all things diabetes. We really appreciate you joining us.
Yes. Well, thank you for having me. It was my pleasure. And I hope that was helpful to your audience.
I promise. Super helpful. Much appreciated.